Welcome to our webinar today. Topic, Tips for Drug Treatment of Pain and Anxiety in the Elderly. This project was facilitated by the California Culture Change Coalition under contract number 13-20-555 with the California Department of Public Health and funded by the Centers for Medicare and Medicaid Services for the California Partnership to Improve Dementia Care. My name is Martha Pauley. I'm a faculty member at California North State University College of Pharmacy, a board-certified psychiatric pharmacist and certified geriatric pharmacist. I've been a long-term care consultant for many years. I have no relevant financial relationships to disclose. What are our goals for today? As pharmacists, we can advocate for delivery of healthcare that is person-centered and goal-directed. And in our topic today, that is to advocate for appropriate use of medications for pain and anxiety in the elderly. When we think about pain, we're really considering it as the fifth vital sign. So chronic pain, the term, has been replaced by persistent pain as the preferred term. And this type of pain may or may not be associated with the disease process, but we know that arthritis, osteoarthritis, and other syndromes are common. Nighttime pain from muscle cramps, restless legs, or claudication is also common in the elderly, and we know that pain is both under and over-treated. Rational polypharmacy does exist, and by that I mean that more than one drug may be necessary to reach a good therapeutic endpoint, as long as they have complementary mechanisms. And when we're considering under and over treatment, it may be that under treatment is the more common in the elderly. People tend to underreport their pain in this age group. Looking at non-pharmacologic approaches, those are important. Things like physical therapy, education in general for patients and caregivers, cognitive behavioral therapy can be used. And these non-pharmacologic approaches can be used with drug therapy, of course. The general approach to pain management in older people differs slightly from that in the younger age group. What are some concerns regarding pain in the elderly? Those elderly with mild to moderate impairment can usually respond to self-reported pain scales. Pain meds may address agitation and aggression without causing the serious side effects associated with antipsychotic drugs. Some patients with dementia who have these signs, agitation or aggression, may actually have unrecognized pain. This emphasizes the importance of assessing and treating pain in those with dementia. Of course, for pain meds, standing orders are preferred over PRN for persistent pain. Patients may not be able to request a medication appropriately. In those people with severe impairment, we may only be able to ask a few questions, observe behaviors, and gather information from caregivers. In doubt, a trial of analgesics is recommended to avoid the risk of undertreatment. It's important to educate the patient and family about recognizing signs and symptoms of pain. We all have a moral obligation to prevent suffering. What are some pharmacologic changes in the elderly that may have a bearing on their response to pain medications? In general, we can say older people have an increased analgesic sensitivity, such as to opiates, and are more at risk for adverse drug events. So when looking at absorption, the GI transit is slowed. Transdermal changes, however, don't occur. So patches, we don't have to worry specifically about changes when we use a transdermal patch. As far as distribution goes, elderly have increased body fat. This might cause an increased volume of distribution for fat-soluble drugs or a longer half-life of these agents. When we look at metabolism, a couple things to point out. Oxidative metabolism is variable, but the conjugative metabolism is preserved. Genetic polymorphisms might also play a role in how fast or slow or completely a drug is metabolized, and this might yield different responses to drugs. When we look at the kidneys, the GFR is decreased, so active metabolites may actually accumulate as the kidneys decrease their function. The World Health Organization is famous for promoting the pain ladder, the three-step pain ladder that most people are familiar with. And even though that pain ladder was first published in 1986. There have been some adaptations since then, but it is still a guide and a valuable contributor to this discussion. Some of the main commonalities or main things that we can agree on from the World Health Organization are these tenets. Oral drug administration is preferred when possible. The drugs need to be dosed at regular intervals. They can be prescribed according to a pain intensity that's evaluated by a scale. The dosing needs to be adapted to the individual, and drugs need to be prescribed with constant concern for details. There are no clear recommendations for age-adjusted dosing in the elderly, but we usually go by the saying, start low, go slow. So when we look at pharmacologic management of persistent pain, we can break it down into a couple of different categories of pain. Back pain, for example, is common, and we have a variety of agents to choose from. Acetaminophen, short-term use of opioids, and then other agents such as tramadol, tricyclic antidepressants, and anti-epileptic drugs. When we think about fibromyalgia, a more chronic condition, we also can consider acetaminophen. Opioids are not recommended, but we can use the remaining agents, tramadol, anti-epileptic drugs, SNRIs, pregabalin, or duloxetine. When we think about neuropathic pain, we also consider acetaminophen. NSAIDs are rarely effective here, and we have the other treatment modalities, anti-epileptic drugs, SNRIs, tricyclics, baclofen, and then possibly opioids. We also have some topical choices such as lidocaine patch or capsaicin. And then when we look at cancer pain, that's maybe a subset, often called malignant pain. It can include acute, persistent, and breakthrough. Multiple etiologies and classification systems exist, and many times we use helper agents such as calcitonin and bisphosphonates, which are helpful for bone pain. And we generally are speaking about using opioids here. So let's look at these individual agents one at a time here. Acetaminophen is an often overlooked drug. It is effective for low back pain and osteoarthritis. And generally, lower doses are not required for treating the elderly. We do have the issue of total daily dose to consider, though, and generally, we should not exceed 3 grams a day or be under that for daily dosing in total. And this includes its use in combination products and alone. There's also an increased risk of hepatotoxicity when used with alcohol. So we want to minimize concurrent use, or if we do use it, we need to reduce the total daily dose to maybe more like 2 grams to 2.6 grams per day. There's also a possible increased risk of bleeding with warfarin. We have inconsistent evidence here, and the mechanism is not fully elucidated, but there are some reports of increased INRs when chronic acetaminophen is used. This drug is a good initial first choice therapy because it's not associated with GI bleeding or other adverse renal effects or cardiovascular toxicity. Moving on to the next group, the nonsteroidal anti-inflammatory drugs. These drugs may be preferred agents when we do have inflammation as a component of the pain. But we also know that there's an increased risk of bleeding, and that the bleeding risk is dose and age related. So it does increase in frequency and severity with age. Proton pump inhibitors are sometimes used to help decrease this risk. But we should be aware that there are additive risks with warfarin or low-dose aspirin used concurrently, and possible additive risks with SSRIs. And we generally use the word possible there because it usually is listed as a potential drug interaction. And if we have a concern about it, then sertraline or citalopram are probably the safest agents to use. So we also know that there's also increased risk of GI or esophageal ulceration when these drugs are used with bisphosphonates. And then we also have the issue of increased risk of sodium fluid overload or renal dysfunction. So antihypertensive drug effects may be inhibited. So when we're looking at the NSAIDs use with the antihypertensive drugs, we're really talking about three main adverse events, and those would be deleterious blood pressure control, effects on renal function, and heart failure maintenance. When we look at NSAIDs in a bit more individual way, we can see that the COX-2 agents, such as Celebrex, may have a decreased GI risk, but the flip side is that they may have an increased cardiovascular risk. We may still need to use a PPI if used with aspirin. When we look at topical agents, such as Voltaren gel, we know that if a topical agent is used concurrently with an oral agent, there's an increased GI risk. And the manufacturer of Voltaren gel actually recommends not using it with oral agents and views this as a duplicate therapy. We have no clear consensus on which NSAIDs are less risky than others. We do have some evidence that naproxen may have less cardiovascular toxicity, and we know that ketorolac and indomethacin, for example, are probably the worst examples to use for long term. The AGS guidelines talk about rare and cautious use and avoiding their use if the patient is 75 years of age or older for chronic pain. Routinely assessing patients for GI and renal effects, hypertension, heart failure, and goals of therapy is important on a continuing basis when we do use NSAIDs in the elderly. Let's move on to opioids. We do have controlled trials that show effectiveness for many types of pain. There are some questions about long-term effectiveness for non-cancer pain. We need to do a couple things: balance efficacy and risks of opioids compared to other therapy, and balance harms of unrelieved pain and potential adverse effects of opiates. The risk of abuse in older persons is low. So older people may not even want to take the opioids because they have a fear of addiction or of some other social stigma. So we can consider opioids for the elderly patients with persistent pain. We know that healthcare providers write many prescriptions. In 2012, healthcare providers wrote 259 million prescriptions for opioids, which is enough for every adult in the United States to have their own bottle. Recent CDC news suggests that MDs are urged to curb opiate prescribing. This came out in December of 2015, and the CDC is proposing new guidelines that are more comprehensive. So we understand we have a crippling epidemic of addiction in the United States, and we have a surge of drug-related overdoses with opiates and even heroin. The American Academy of Pain Medicine and the American Pain Society both have guidelines to help clinicians assess and monitor patients with persistent pain and use opioids responsibly. And the AGS panel on the pharmacologic management of persistent pain in older adults, and I have this referenced at the end for you, does recommend use of opioids in geriatric patients, irrespective if at the end of life or not. When we look at specific opioids, we have many choices available. I've listed a few there. Let's look, for example, at morphine, which comes in many different forms. One of the forms that's used most commonly is Roxanol, or oral liquid form. It's very commonly used for episodic or breakthrough pain or in those unable to swallow. But the SR forms are usually started after initial dose is determined by the effects of the immediate release opioids. And in morphine, we have several kinds of SR forms, such as Avinza, Cadian, MS-Contin, or Oromorph. Methadone is not really first line, but has been used in cancer patients, in those with persistent non-cancer pain and intractable neuropathic pain. We need to be mindful of the fact that it has a variable half-life and nonlinear dosing. Fentanyl patches are commonly used. They're not for opioid naive people. For example, the lowest fentanyl patch is equivalent to about 60 milligrams of oral morphine, and it may take greater than the time of one patch to reach steady state, so not for acute treatment of pain. Dose conversions need attention. whether we're talking about dose conversions between IV or parenteral forms and oral forms or among oral agents. And we need to count acetaminophen in combo meds as part of the total not to exceed acetaminophen component. What about a bowel regimen? Constipation is an extension of the pharmacology of opioids. It's not a surprise side effect. It's a routine side effect. So we need to be preventive here. Senna, prunes, sorbitol, lactulose, or bisacodyl are generally the preferred agents. Stimulants are basically the drug of choice, then osmotics. The second line group, stool softeners, psyllium with adequate fluid, are generally not enough and not first line. The nausea and vomiting that sometimes occurs with opioids is treated with antiemetics, and the nausea and vomiting side effect may decrease over time. We also need to point out that opioids can induce a delirium that's corrected by decreasing the dose. Tramadol. This is an interesting agent because it's a mixed opioid, norepi, or serotonin reuptake inhibitor, but we need to monitor for opioid side effects. And the added issue is the possible serotonin syndrome with other serotonergic drugs, such as SSRIs or SNRIs or even dextromethorphan. The pain meds that may have the most risk for serotonin syndrome are fentanyl, meperidine, and tramadol. If serotonin syndrome were to occur, the symptoms usually occur within the first 24 hours of the co-administration of serotonergic drugs. And remember, the hallmark components of serotonin syndrome are altered mental status, autonomic instability, and alterations in muscle tone. A very difficult thing to, quote, monitor for, unquote. Let's look at some other agents that are occasionally used for pain. First, we have gabapentin and pregabalin, two anticonvulsants. It's important to monitor these agents for sedation, ataxia, or edema. When we look at the use of lamotrigine and carbamazepine, also anticonvulsants, we need to also be aware of a couple things. Lamotrigine, monitor for sedation, ataxia, or cognitive decline. There are also rare cases of Stevens-Johnson syndrome. With carbamazepine, we need to monitor some labs, possibly serum levels, and be mindful of drug interactions. Carbamazepine has the propensity to cause autoinduction, so serum levels may decrease over time. When using a lidocaine patch, an important thing to remember is the dosing parameter. It should be applied on for 12 hours and off for 12 hours. It may cause a skin rash because it's usually applied at the same spot on the body. The question of can people absorb enough lidocaine systemically to lead to problems? This systemic lidocaine level remains within the safe range when doses of up to 4 patches are used concurrently on the appropriate schedule. Another topical agent that's not listed here is capsaicin. This is known for causing the burning sensation when it's applied. This drug depletes substance P, which is an important factor for pain perception. It may not do this, however, for several weeks, and so consistent treatment gives the best response. Then we also have the group of muscle relaxants that are listed here. We need to be especially careful about monitoring for anticholinergic side effects, sedation, muscle weakness, and falls. And of course, these are drugs that are on the Beers list. Then we also have duloxetine or Cymbalta. We need to monitor for blood pressure, drug-drug interactions, but it does have usefulness for neuropathic pain. And in fact, it has several FDA indications in the pain area, such as diabetic peripheral neuropathic pain, fibromyalgia, or chronic musculoskeletal pain. I did not include the tricyclics here as they do have greater risks in the elderly due to the anticholinergic side effects, but we know that low doses are helpful as an adjunct in neuropathic pain. In adults, it's just that they have more risks and adverse drug events in the elderly. What about other alternative agents such as glucosamine? Here we're talking about a medicine that does have some benefit for reducing pain and even possibly slowing progression of osteoarthritis. The sulfate salt is preferred over the hydrochloride salt because most studies have been done using the sulfate salt. This drug can cause mild GI upset, heartburn, diarrhea, or even on occasion insomnia. Generally, the doses are 1,500 milligram per day. That can be in one dose or split to either BID or TID. You might also find glucosamine in combination with chondroitin, MSM, or even SAMe. There's information available on a couple of sites. The National Institutes of Health, National Center for Complementary and Alternative Medicine website is listed there. And then, of course, Pharmacist Letter Natural Database. We might also mention the cannabinoids, Sesamet and Marinol. They do cause dizziness, sedation, cognitive effects, and hypotension in the elderly. The therapeutic window for these agents is narrow, and dysphoric responses in the elderly are common. I wanted to point out the topic of pharmacogenomics in pain management because this is becoming more important. As we learn more about the polymorphisms in the cytochrome P450 system, for example, we know that these differences in the way we metabolize drugs can have an impact on how we perceive pain and how we are treated with pain meds. For example, people that are poor metabolizers of CYP2D6 may have an increased toxicity risk with usual substrate drugs that are metabolized by that system. Conversely, they may have a poor response if drugs are prodrugs of that system and they're not allowed to be metabolized to the active component. And then when we look at the other side of the spectrum, ultra-rapid metabolizers of cytochrome P452D6, they have a poor response to the usual substrate drugs because they're quickly metabolized, and they have a risk of toxicity for prodrugs that are metabolized quickly to the active moiety. An example here might be codeine, which is a prodrug, and when it's changed to morphine in a rapid way by ultrametabolizers, toxicity of morphine can result. So there are also drugs that are not metabolized here, morphine, hydromorphone, and oxymorphone, for example. So these might be drugs of choice if we know metabolic status of the cytochrome P450 system in our patients. There are other systems besides the cytochrome P450 system that play a role: enzymes, transporter genes, opioid receptor genes, and differences in these all play a role. I've cited here a review article, Pharmacogenetics of Chronic Pain and its Treatment, for your review for more information. But this is a really increasing and interesting area of research. So let's switch a bit and talk about anxiety in the elderly. Late life anxiety can be difficult to diagnose. There are undercurrents of pain, breathing trouble, and nausea, for example, and other multiple comorbidities. There's also an overlap with depression. Anxiety is twice as prevalent as dementia. The two most common are generalized anxiety disorder or specific phobias. But in dementia, we need to watch for physical signs or an anxious appearance. And again, I want to remind people that akathisia from use of antipsychotic drugs can mimic anxiety, and that akathisia can also occur from metoclopramide, not just antipsychotic drugs. So anxiety can have an impact on quality of life, a negative one, and increase morbidity and mortality. We have a variety of treatment modalities, medication, cognitive behavioral therapy. There are a number of medical conditions associated with late life anxiety, and some of these are listed in general categories here. Addressing these causes may help the treatment of anxiety. There are also some medications that may cause anxiety, and I've listed a number of them here, including over-the-counter things such as caffeine or herbal drinks and supplements, and then prescription agents. Albuterol is a common one. Many people use inhalers multiple times a day instead of in a rescue way, and so heart rate and blood pressure can increase, causing anxiety. We know that antidepressants can sometimes cause anxiety, such as fluoxetine might be a good example for that. And then levothyroxine or thyroid replacement therapy, which may alter thyroid hormone status, might be a contributor to anxiety. Benzodiazepines or alcohol withdrawal might also be a problem. And then, of course, stimulants or pseudoephedrine. So how do we treat anxiety in the elderly? Well, we know that first line is antidepressants, and usually that means SSRIs, but it can also mean SNRIs or mirtazapine. And then second line is benzodiazepines. For acute treatment, benzodiazepines are sort of the gold standard because they work immediately, whereas the antidepressants, as you know, require several weeks of dosing for maximal benefits and fair therapeutic trials. We also have other options such as buspirone, which might actually be first line in generalized anxiety disorder. What are some of the challenges of using antidepressants? Well, one of the first caveats is go low with our initial dose. So when we look at SSRIs, generally sertraline, escitalopram, and citalopram are preferred agents, and less preferred or less desirable are fluoxetine, paroxetine, and fluvoxamine. For example, paroxetine is on that list because it has anticholinergic side effects. And fluoxetine is one of the more activating, if you will, SSRIs, which may contribute to anxiety rather than treat it. There's an increased risk of bleeding in the elderly noted with SSRIs. This absolute risk of upper GI bleed with SSRIs alone is about 1 in 300 patient years. And when we look at SSRIs plus aspirin, that decreases to 1 in 200 patient years. And when we look at SSRIs plus NSAIDs, it decreases even further to about 1 in 80, where the risk of NSAIDs alone is about 1 in 200. So we know that NSAIDs cause bleeding by damaging the mucosa, and SSRIs have a different mechanism that involves decreasing the effectiveness of normal clotting mechanisms. When we look at venlafaxine, duloxetine, or mirtazapine, those are also sometimes good choices of antidepressants to treat anxiety. Venlafaxine may cause increased blood pressure, so there's a hypertension risk there that might be problematic in some patients. Duloxetine might be helpful in those with associated pain syndromes, and mirtazapine is a sedative at low doses, higher doses less so, but may be another option. We need to monitor all drug treatment for worsening anxiety, insomnia, and initial GI side effects that occur with antidepressants. What about the challenges of benzodiazepines? Well, they have some pretty prominent pros, but they also have a lot of cons. So the pros are rapid onset, as we mentioned, not taking weeks for a fair therapeutic trial, and effective relief of symptoms. But there are a number of cons. People can be oversedated, they can have cognitive impairment, they can have poor motor coordination or psychomotor incoordination. The risks are there: tolerance, dependence, and abuse. Very dangerous and overdose, especially combined with alcohol. And then we have the issues of rebound and withdrawal. Let's look at the common anti-anxiety benzodiazepines. Again, we can group them into short-acting, intermediate-acting, and long-acting, which are basically the worst choice for the elderly. But looking back at the short-acting, Xanax is the most popular. This drug has a rapid onset and a rapid end. It can cause rebound insomnia, rebound anxiety, or interdose anxiety could also be common. The intermediate choices there, lorazepam and oxazepam, are interesting drugs. Lorazepam, we're talking about doses of 0.25 to 0.5 every 8 to 12 hours or so, possibly PRN. And for oxazepam, 10 milligrams Q8 to 12 hours, possibly PRN. These two are generally preferred for anxiety in the elderly. They have the conjugated metabolism, which doesn't change with age. They also have an intermediate action and no active metabolites. The long-acting drugs, such as Valium, Librium, or Klonopin are listed. These either have a very long action or active metabolites which build up over time. So this could cause obtundation, excessive sedation, and extreme fall risk. So all the benzodiazepines are Schedule 4, and they all do carry the four main properties of the class. They're sedatives, they're anti-anxiety agents, they're muscle relaxants and anticonvulsants, depending a little bit on structure and receptor activities. Let's look also at benzodiazepine withdrawal. We know that rebound effects are more frequent with shorter half-life benzodiazepines, such as Xanax. The onset of rebound effects can occur within 1 to 4 days after stopping, and they can generally last 2 to 3 days. There's also a withdrawal syndrome. This occurs in about 30% of patients on benzos for more than 6 weeks. This can have almost a 2-week duration. Common symptoms are anxiety, insomnia, of restlessness, muscle tension, and irritability. Less common are things like sweating, nausea, blurred vision, nightmares, depression, hyperreflexia, or ataxia. And rarely, hallucinations, confusion, paranoid delusions, and seizures may occur. Let's look at benzodiazepine withdrawal. There are some things that confer a highest risk. These would be things like higher daily doses, shorter half-life agents, a longer duration of therapy, and a more rapid taper attempt. These are all factors that might lead to risk of withdrawal. So what are some general tapering recommendations? Tapering by about 25% of the dose weekly until half of the total daily dose is reached is one suggestion. The remaining taper needs to be more prolonged, such as 1/8 of the dose every 4 to 7 days. Some people might need it to be even slower than that. If a person is on short-term therapy, the taper can be accomplished over about 3 weeks. If therapy has been for a longer time, such as greater than 6 months, the taper may need to be 8 weeks long. And therapy of greater than a year, taper might need to be over 4 months. The switch from using a short-acting to a long-acting benzodiazepine for this withdrawal process is controversial. Sometimes it's recommended and sometimes it's used, but other times it isn't. Let's talk a little bit about benzodiazepine drug interactions. Of course, we have the two main types. Pharmacodynamic drug interactions are easier to predict because we know their pharmacology, and additional CNS depression occurs when we use more than one agent. Pharmacokinetic drug interactions are a little bit harder to predict, but we know that if you use a cytochrome P453A4 inhibitor, such as some of those listed above, we can have increased levels and risk of toxicity. Grapefruit juice also is a 3A4 inhibitor and can increase levels of diazepam or alprazolam. Omeprazole can also increase diazepam. And then valproic acid can decrease the clearance of lorazepam, even though it has a simpler metabolism and is generally a preferred agent in certain cases. Continuing on to look at other agents, buspirone is a non-benzodiazepine anti-anxiety agent. It does have low potential for dependence and adverse effects. It is not effective as a PRN, as are benzodiazepines, and needs continuous dosing to be effective. It may require actually several weeks of dosing before full effect is seen. Cholinesterase inhibitors might be another consideration because we know that these drugs may improve anxiety, irritability, or aberrant nighttime behaviors in those with Alzheimer's disease, but they may also cause insomnia, urinary frequency, dizziness, and fatigue. So challenges of treating pain and anxiety. We need to make sure that we're choosing the right drug, the correct dose for that individual, the appropriate interval of use, and the appropriate length for treatment. And this means that we need to have a treatment plan in place. The whole healthcare team needs to be part of this, as does the patient and or caregivers. We need to watch for medication errors that may sometimes occur, whether this is a transcription error or error in dosing or just any other error that occurs in the process. We need to conduct ongoing monitoring for side effects and efficacy. So when we're speaking about anxiety, we know that drug orders need to have a diagnosis, target symptom, and side effect monitoring order component of that order, and we need to think about gradual dose reductions. We need to think about also recognizing side effects and adverse drug events, and of course, preventing drug interactions. Over time, symptoms and goals may change, so reassessment on a common basis is crucial. And this brings us back around to the idea of patient-centered care, using non-drug modalities and paying attention to the transitions between healthcare settings. I've provided some references or resources for your review. This brings us to the end of this webinar. Thank you for listening and have a great day.